In this part of the test, you'll hear a consultation between a health professional and a patient. For questions 1 to 12, complete the notes with information you hear. Write a word or short phrase in each gap. You now have 30 seconds to look at the notes. OET Listening Part A, Extract 1, Q1 to 12. You hear a gastroenterologist talking to a patient called Mr. Daniel Fraser. You now have 30 seconds to look at the notes.
This is Official Listening Sample Test of OET by Dr. Nasir.
Good morning, Mr. Fraser. Please, come in and take a seat.
Morning, Doctor. Yes, thank you.
So, I see from your referral that you've been having some stomach trouble. Can you tell me when the symptoms began?
About 5 days ago, I started experiencing quite severe abdominal cramps, mostly after meals.
I see. And does the pain occur in any particular area?
Yes, mainly in the lower right side, although sometimes it spreads across my abdomen.
Have you had any other symptoms? Vomiting, fever, or changes in your bowel habits?
I haven't vomited, but I've had loose stools about 3 or 4 times a day, and last night there was even a trace of blood.
That's important. Any nausea or loss of appetite?
Yes, my appetite has been much lower than usual. Even when I try to eat, I feel full quickly.
Do you recall if anything triggered these symptoms? Perhaps a new diet, foreign travel, or a recent infection?
Well, I did attend a barbecue with friends about a week ago. A couple of others also complained of stomach issues afterwards, but they seemed to recover more quickly than I have.
Understood. And do you have any family history of digestive disorders, such as ulcerative colitis, Crohn's disease, or bowel cancer?
My sister has Crohn's, though I've never had anything like this before.
Are you taking any regular medications?
Just an occasional ibuprofen for back pain. No prescribed drugs.
Noted. Well, from your symptoms, abdominal cramps, loose stools, some rectal bleeding, it could be an episode of infective colitis, possibly linked to contaminated food. But because of your family history, we also need to consider inflammatory bowel disease.
Does that mean it might be Crohn's like my sister?
It's one possibility, yes, but not certain. Crohn's usually presents with long-standing symptoms and weight loss, whereas yours seem to be more acute.
So what happens now?
I'll order a stool culture to check for bacterial infection, as well as some blood tests to look at your inflammatory markers. If results are inconclusive, we may need a colonoscopy to visualize the bowel directly.
Oh, I was hoping to avoid that.
Don't worry, it's not the first step. In the meantime, drink plenty of fluids, avoid spicy food and alcohol, and rest. If the diarrhea worsens or you develop a high fever, you should come straight to the hospital.
Understood. Thank you for explaining everything so clearly.
You're welcome. Let's get those investigations underway.
Questions 13 to 24. You hear a GP talking to a patient called Mrs. Clara Jennings. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
OET Listening. Part A, Extract 2, Questions 13 to 24.
This is Official Listening Sample Test of OET by Dr. Nasir.
Good afternoon, Mrs. Jennings. I was a little surprised to see your name on my list today since you were just here for a full checkup a couple of weeks ago. Everything looked fine then. What brings you in so soon?
Afternoon, Doctor. Yes, I know it's a bit sudden, but something happened earlier today that really worried me.
Okay, tell me what happened.
Well, around mid-morning, I was sitting at my desk typing an email when I suddenly felt this sharp discomfort in my chest. It wasn't like anything I'd experienced before. The pain spread into my left arm and shoulder, and I started sweating quite a lot.
That does sound concerning. How long did the pain last?
It was very intense for about 10 minutes. Then it eased off, though I've still got a sort of dull heaviness.
Did you feel short of breath at the time?
Yes, I was quite breathless, and I also felt slightly dizzy, like the room was spinning.
Did you experience nausea or vomiting?
I felt a bit queasy, but didn't vomit.
I see. Have you ever had anything like this before?
No, nothing. I mean, I sometimes get a bit of indigestion after spicy food, but this felt very different.
Understood. Do you have any family history of heart disease or stroke?
Yes, my father had a heart attack at the age of 62, and my mother has high blood pressure.
And do you smoke?
I used to, but I quit 5 years ago. I still have the occasional cigarette at a party, though not daily.
How about alcohol intake?
A glass of wine maybe once or twice a week.
And medication? Are you on anything at present?
Just lisinopril for mild hypertension and occasionally an antihistamine for hay fever.
All right. On examining you now, your blood pressure is slightly elevated, and your pulse is regular, but a bit fast. Given the nature of your pain, its radiation to the arm, and your risk factors, my concern is that you may have had an episode of angina, or even a mild cardiac event.
Oh goodness, you mean like a heart attack?
Possibly, though not necessarily. Angina occurs when the heart muscle doesn't receive enough oxygen due to narrowing of the coronary arteries. A true heart attack happens if the artery becomes completely blocked. Your symptoms do suggest we should investigate urgently.
What will you need to do?
I'm going to arrange an ECG immediately, as well as blood tests to check your troponin levels. Those will show if any damage to the heart muscle has occurred.
And if it is angina, what happens then?
You would likely be started on medication, something like nitrates to relieve the chest pain, beta blockers to reduce the workload of the heart, and possibly aspirin to reduce clotting. Depending on results, you may need to see a cardiologist for further tests such as an angiogram.
That sounds serious.
It can be, but the good news is that if detected early and treated, the outcomes are usually very good. Lifestyle changes will also help. Maintaining a healthy weight, regular exercise, reducing stress, and of course avoiding smoking altogether.
I walk my dog daily, but I suppose I should step it up.
Yes, but gradually. Don't suddenly start strenuous exercise. Walking is excellent, but listen to your body and stop if pain recurs.
Should I be admitted to hospital right now?
Given that you are currently stable, I'll have the tests done immediately here, but if they show any abnormality, we'll admit you straight away for monitoring. If your symptoms worsen before then, if you develop severe chest pain, sweating, or breathlessness, you must call emergency services immediately.
All right. I did think at first it might just be indigestion, but it felt more alarming than that.
Exactly. Indigestion usually improves with antacids and isn't typically associated with pain in the arm or excessive sweating. That's why your case is different.
Thank you, Doctor. I'm glad I came in today.
Absolutely. You did the right thing by not ignoring these symptoms. Many people dismiss chest discomfort as minor and delay seeking help, which can be dangerous.
Will I still be able to go to work tomorrow if the tests are clear?
Let's wait for the results. Even if the tests are reassuring, I'd recommend taking a couple of days to rest and avoid unnecessary stress.
Okay, I'll inform my manager.
Good. Let's get the ECG done now, and we'll review the findings shortly.
You hear a physiotherapist briefing a nurse about a post-operative patient. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 20 seconds to read the question. You will hear a beep before the audio starts. This is Official Listening Sample Test of OET by Dr. Nasir.
So, about Mr. Langley in bed 12. He had his hip replacement 3 days ago. His wound looks fine, and the pain seems reasonably controlled with oral analgesics. The main issue now is getting him moving safely. He's still hesitant to put full weight on the operated leg, which is slowing down his progress. I explained to him this morning that gentle mobility is absolutely crucial at this stage to avoid stiffness and reduce the risk of clot formation. Out of the exercises I've shown him, the most important right now are ankle pumps and short walks to the bathroom with the frame. If he delays these, recovery will stretch out unnecessarily. Could you please encourage him when you're on the round? Just reminding him that these movements are priorities will really make a difference.
You hear a department manager talking to staff about training sessions on autism. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 10 seconds to read the question. You will hear a beep before the audio starts.
Before we move on to other matters, I want to clarify why we've scheduled mandatory training sessions on autism awareness. Some of you have asked whether it's really necessary since not every member of staff works directly with patients who are on the spectrum. The point is that autism affects communication in ways that aren't always obvious. Even brief interactions in reception or during routine appointments can be stressful for someone with sensory sensitivities. The aim of this program isn't to turn you into specialists, but to make sure you recognize signs of distress, avoid common triggers, and adjust the environment where possible. This is about improving the overall patient experience and ensuring our service is inclusive. Attendance is therefore required for everyone, regardless of role.
You hear a senior nurse giving a briefing to her staff about safety issues on the ward. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 10 seconds to read the question. You will hear a beep before the audio starts.
All right, team, before we start rounds, a few updates on patient safety. First, Mr. Patel in Bay 3 has been restless overnight and tried to get out of bed without assistance. Please remember he's at high risk of falling, so make sure his call bell is within reach and assist him promptly when needed. Next, Mrs. Clark has developed a small pressure sore on her heel. She's hesitant to change position, so do encourage regular turning and keep her heel protected with the cushion pads provided. Now, most importantly, we have Mr. Hughes in side room 4. He presented this morning with diarrhea and vomiting, so we need to take isolation precautions straight away and complete the infection screening forms before anything else. Once that's done, Mrs. Webb is awaiting repeat MRSA swabs. That's the final step before she can be considered for discharge, but it isn't as urgent as infection control.
You hear a senior doctor briefing a junior doctor about patient management. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 10 seconds to read the question. You will hear a beep before the audio starts.
Before you prescribe for Mr. Williams, I need to highlight something. He's already on AC inhibitors for his blood pressure, and I noticed you were about to chart ibuprofen for his back pain. That combination can be risky.
Oh, I thought ibuprofen would be fine in the short term.
Not necessarily. When you mix AC inhibitors with NSAIDs, especially in an older patient with slightly reduced kidney function, you increase the chance of acute renal injury. Even a few doses can tip the balance. His creatinine yesterday was borderline, so we shouldn't take chances.
Right, so what would you suggest instead?
Paracetamol would be safer. If stronger analgesia is needed, we could consider opioids, but definitely avoid NSAIDs here. Please adjust the chart and document the rationale clearly.
You hear two doctors discussing a patient's treatment plan. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 10 seconds to read the question. You will hear a beep before the audio starts.
I've just gone over Mr. Patel's latest observations. His oxygen levels improved after the nebulizer, but His breathing rate is still sitting around 26. What I'm thinking is that now he's more awake and responsive, we could change to the metered dose inhaler with a spacer instead of continuing nebulizers every few hours.
Yes, I was considering the same. Earlier, he was quite drowsy, which justified using nebulizers, but he's definitely more alert now. With the spacer, we'll avoid over-oxygenating him, and it's easier for nursing staff to administer consistently.
Exactly. We'll prescribe 4 puffs every 4 hours, check his peak flow before and after, and reassess his response. If there's any deterioration, say a fall in saturation or increased wheeze, we can revert to nebulizers temporarily.
Agreed. I'll make a note to review his steroids as well, but for now, let's keep the current prednisolone course unchanged. I'll document the inhaler switch in the chart so the team is clear on the plan.
You hear a senior nurse clarifying details about an upcoming training session. Choose the answer, A, B, or C, which fits best according to what you hear. You now have 10 seconds to read the question. You will hear a beep before the audio starts.
I just want to clear up some confusion about next week's manual handling training. A few staff thought it was optional, but it's actually mandatory for all ward personnel. That includes permanent staff, agency nurses, and even students on placement. Another point to clarify, this session isn't about learning to operate new hoists or equipment, although those will be mentioned. The real focus is on reducing injury risk when lifting or transferring patients. We've had several incidents of back strain recently, so the training is aimed at improving technique and consistency. Finally, some people assumed they could attend only the morning or afternoon portion. In fact, you'll need to complete the full-day course to be certified. Attendance will be logged, and failure to attend means you'll have to reschedule before being rostered for certain shifts. So, to be absolutely clear, the training is compulsory. It covers safe handling practice, and full attendance is required. OET Listening Part C, Extract 1, Q 31 to 36.
This is Official Listening Sample Test of OET by Dr. Nasir.
Good morning, and thank you for the opportunity to share findings from our recent multi-center study on the relationship between the gut microbiome and depressive disorders. Over the last decade, there has been increasing interest in what is sometimes called the gut-brain axis. In simple terms, this refers to the two-way communication between the gastrointestinal tract and the central nervous system. But while the concept is appealing, the evidence has often been criticized as either anecdotal or drawn from animal models with questionable application to human health. Our trial, conducted across 3 European countries with over 2,400 participants, aimed to address precisely this gap. We examined stool samples, dietary logs, and psychiatric evaluations to determine whether distinct microbiome patterns correlate with the severity of depressive symptoms. Interestingly, we did not find a single bacterial strain consistently linked to mood disturbance. Rather, what emerged was a pattern of reduced microbial diversity overall, coupled with lower levels of specific short-chain fatty acid-producing bacteria. This is important because earlier, smaller studies had suggested a magic bullet bacterium, usually bifidobacterium or lactobacillus, as though supplementing them alone could resolve depression. Our findings suggest that the issue is far more complex, requiring an ecosystem perspective rather than reliance on one probiotic pill. One striking observation was how dietary fiber intake moderated the results. Participants with high-fiber diets showed much greater resilience even when their microbial diversity was limited. That points to lifestyle as a powerful confounder. It is not enough to prescribe probiotics. The overall nutritional pattern must be considered. We also encountered skepticism. Some psychiatrists in the trial insisted the apparent improvements were due more to cognitive behavioral therapy than to microbiome changes. To account for this, we ran a subgroup analysis of patients who did not receive psychological therapy, and the association with microbiome diversity still held. However, I must stress, association does not prove causation. Whether microbial imbalance leads to depression, or whether depression and its behaviors, irregular meals, alcohol misuse, social withdrawal, cause the imbalance, remains unresolved. Let me illustrate with a case. A 34-year-old man presented with recurrent major depressive disorder resistant to multiple antidepressants. He had long-standing irritable bowel symptoms. Following structured dietary counseling and gradual reintroduction of fiber-rich foods, his gut profile improved substantially, and 6 months later, his depressive episodes were notably shorter. But was this because of microbial change, improved nutrition, or simple placebo? The answer is unclear, and this is why large-scale longitudinal studies are essential. It's also worth noting the gender differences in our data. Women were more likely to show gut-mood correlations than men. Whether this reflects hormonal influences, dietary patterns, or even reporting biases remains speculative. Now, what does this mean for practice? Some clinics have rushed ahead with so-called psychobiotics, offering expensive capsules marketed directly to patients. I would urge caution. While there is promising evidence, we are not yet at the stage where one can recommend a specific probiotic formulation as first-line treatment for depression. Instead, our report concludes that maintaining microbial diversity through balanced diet, regular sleep, and exercise may be as valuable as medication adjustment in selected patients. Finally, I want to acknowledge a limitation of our study. Stool analysis provides only a snapshot of microbial communities. The functional aspects, what metabolites these microbes actually produce, may be more important than their mere presence. We are therefore embarking on a new project, tracking metabolomic changes alongside psychiatric outcomes over the course of 2 years. So, to summarize, there is a robust association between reduced microbial diversity and depressive symptoms. The relationship is not straightforward. Diet, lifestyle, and therapy all interact. There is no single miracle bacterium that explains everything. Clinical practice should focus on holistic management, not unregulated supplements.
This is Official Listening Sample Test of OET by Dr. Nasir.
Good afternoon, Professor Malik, and thank you for joining us. As you've recently led a major study on the use of telerehabilitation for stroke patients. To begin, could you briefly explain what telerehabilitation involves?
Of course. Telerehabilitation refers to the delivery of structured therapy remotely, often using digital platforms such as video calls, mobile applications, or wearable sensors. Instead of visiting the hospital physiotherapy department 3 or 4 times a week, patients carry out supervised exercises at home, with clinicians monitoring progress virtually. The model is designed not to replace traditional therapy entirely, but to extend access to rehabilitation, especially for those living in rural or underserved regions.
And what motivated your team to carry out this particular trial?
Well, stroke is a leading cause of disability worldwide, and outcomes are often limited by inadequate rehabilitation. In the UK, fewer than half of stroke survivors receive the recommended intensity of physiotherapy. Travel to hospital appointments, shortages of staff, and costs all contribute to this gap. Smaller pilot projects hinted that telerehabilitation might help, but they lacked scale and rigorous evaluation. So our goal was to test, in a robust, randomized controlled trial, whether digital delivery could genuinely match or even exceed the benefits of conventional in-person therapy.
Tell us a bit about the design of the trial.
We recruited over 1,600 stroke survivors from 12 NHS trusts. Participants were randomly assigned either to standard face-to-face physiotherapy or to a telerehabilitation program lasting 6 months. Both groups received broadly the same set of core exercises, balance training, upper limb strengthening, gait retraining, but the mode of delivery differed. For the tele group, exercises were guided via secure video link with additional feedback from wearable motion sensors. Importantly, we did not exclude older patients or those with mild cognitive impairment, as critics often argue that such individuals cannot manage technology.
And what did you find?
The results were both encouraging and nuanced. On the primary outcome measure, which was improvement in mobility scores after 6 months, the telerehabilitation group performed almost identically to the conventional group. In other words, remote therapy was not inferior. That said, there were interesting subgroup differences. Younger patients, and those already comfortable with smartphones, tended to engage more consistently. In contrast, some older participants required significant technical support, which increased costs and staff time. So while the overall results were positive, the picture is not uniformly simple.
Were there any surprises?
Yes, several. One was that adherence to therapy, that is, the proportion of scheduled sessions actually completed, was higher in the tele group than in the face-to-face group. Patients reported they found it easier to exercise at home without the burden of travel and felt more in control of their schedules. Another surprise concerned mental well-being. We included validated questionnaires on mood and confidence. Interestingly, patients in the tele group showed slightly greater improvements in self-efficacy, the belief that they could manage their recovery. We had assumed face-to-face contact would boost motivation, but in fact the opposite appeared true for some.
That's fascinating, but were there any drawbacks?
Certainly. Technology failures were a persistent problem. Around 18% of participants in the tele group reported at least one interruption due to poor internet connectivity or device malfunction. In some rural areas, broadband speed was inadequate, limiting the quality of video feedback. Moreover, while most clinicians adapted well, a minority expressed frustration at the lack of hands-on interaction, feeling they could not correct posture or movement as effectively through a screen. These reservations should not be dismissed lightly.
So what does this mean for practice?
Our conclusion is not that telerehabilitation should replace conventional care wholesale. Instead, it should be considered a complementary model. For some patients, especially those geographically isolated or facing transport barriers, it may provide equal or greater benefit. For others, particularly those with complex needs requiring manual facilitation, in-person therapy remains essential. In fact, we argue that the future lies in hybrid approaches, combining digital flexibility with periodic face-to-face assessments.
And what are the next steps in research?
We are now conducting a cost-effectiveness analysis as the economic implications are critical for policy. Early data suggests that While equipment and technical support raise upfront costs, reduced travel and fewer hospital visits may offset these in the long run. In addition, we are developing culturally tailored versions of the program because engagement strategies differ across communities. What motivates a younger, urban patient may not resonate with an elderly rural farmer. Finally, we are planning a 5-year follow-up to see whether early telerehabilitation leads to sustained independence or simply short-term gains.
So in summary, what message would you want clinicians and policymakers to take away?
That telerehabilitation is a viable, evidence-based tool that can expand access and improve patient autonomy. But it is not a panacea. Implementation must be thoughtful, inclusive, and adaptive. We must avoid the temptation to oversell it as a cure-all while also avoiding outdated skepticism. Stroke recovery is complex, and telerehabilitation is one piece of the wider rehabilitation puzzle.